Okay, good evening. We open the meeting now at 7 o'clock, or just a couple of minutes to. Before we begin, I just want to mention something on the items. We are not going to be having a briefing on the homeschooling and school exclusions today. It will be coming out in the next couple of days. Raj tells me Wednesday or Thursday. And as stated on the pre-meeting, if there's any questions from that briefing, please feel free to email in to Raj, and get a response. Okay, so apologies. Sorry, Councillor Maxwell.
So you're talking about homeschooling?
The homeschooling and exclusions that was meant to be, we're meant to be getting a briefing today.
Oh, it's today, but
it was meant to be. We're not anymore, no.
When are we going to do it?
So unfortunately, we probably won't get to do it, proper scrutiny on it before the next administration takes place after the election.
Oh,
yeah.
Sad.
It is, yeah. Thank you.
Sorry, if I could just come in there, Chair. There will be an opportunity to provide. There will be an opportunity to provide some written queries, and we'll receive a response in writing. And then, yeah, as we said, following the elections, when scrutiny activity resumes, that will be added to the forward plan of the necessary committee.
Can I ask you a question? Have you sent the notes out for the homeschooling or not? No. Have you sent the notes out regarding it?
Sent the notes out?
Yeah.
What do you mean by that?
Well, have you actually sent anything out about it?
No, so nothing's been out yet.
No.
Wednesday, Thursday, there'll be a briefing paper.
Oh, this week?
Yes, this week. Apologies.
Oh, you're going to send it out?
Yeah, yeah.
Right.
Well, I won't be sending out the respective officer, but Sharice will be sending it out. Yeah.
Thank you.
Thanks. Now to open the meeting. So apologies for absence. Any apologies?
Yeah, I've received apologies from councillors Anley and Jill Mercer.
Thank you. And members' declaration.
Can I, Councillor Carr, he did send his apologies in. I don't know whether I didn't see that. No, he's gone.
Councillor Count in the minutes. Councillor Riley. Okay, thank you. Members' declarations of interest. Any members declare an interest in any of the items on the paper today? No.
Just one. Yeah. One of the slides has got a mention of Homestead. I'm aware of one of the other franchisees. It won't be the same one for that area, but just to say I'm aware of one personally.
Thank you. And minutes of the meeting held on the 7th of January of this year. Could I get a proposer for that for those minutes, please? Yeah. And seconder. All in favour? All right. Okay, on to the items on the agenda. The Orchard Project. Can I invite Jane? Are you presenting this, or is it?
Assuming that's working, it's going to be a bit of a joint effort, Chair, if that's okay.
Of course it is.
So I'll introduce the project, but then I'm also going to introduce two of our guests that we have here this evening. So we have Jonathan Sheldon, who's one of the trustees from the Autumn Centre, who's very involved with the project. Thank you so much, Jonathan, for sparing the time to come this evening. And also Professor Jackie Parks, who's going to be speaking and presenting as part of this paper as well. And Jackie's a professor at the University of Northampton and been a real drive behind this particular work. So welcome as well, Jackie. So this piece of work is something that I think is really important because dementia essentially affects everybody and can affect anybody. And we know that there's very few people who will go through their lives without knowing somebody who is affected by dementia if that's not themselves. And it's a disease that is very cruel and it can make people feel very isolated. But actually, we've got some fantastic assets in our local area that are supporting people in lots of different ways to live a really fulfilled life and supporting the carers of those individuals. So I'll take the paper as read, but the key aims of the project are shown in 5.4 on the paper, which is on your pack, page 12 of 68. So the project itself is about working really collaboratively with one of our local assets, which is the Autumn Centre in Corby, to develop something that we're calling the Orchard Project, which I think we all found slightly confusing because orchard and autumn are quite similar. But the Orchard Project is about coming together and doing a piece of work which brings together the fantastic staff, service users, families and all the assets that come with the Autumn Centre, with the university and also with us as a council, to say what would a centre of excellence look like in terms of dementia care. How do we use the evidence in the best possible way? How do we develop our own evidence? And what do we do with that in Northamptonshire to make sure we get out all of that great practice across the whole of the patch? So this project is, the first sort of commitment has been for some funding from Public Health to support a PhD student and to do some work at the centre to say what could this excellence look like, how do we develop that? But also the building itself is a council building, and £200,000 of capital funds are going in to help develop that centre to be the best it can possibly be for the people who use that centre, and maybe be a little bit innovative in terms of how that centre is used. And I think from my perspective, what I particularly like about this project is that so many people with expertise, whether that be lived experience, whether that people who've worked for a huge length of time in the voluntary community sector and really know their onions, the best way to put it, but also with our academic partners, I think we get a really fantastic mix of knowledge and experience that's coming together and offering us something a little bit different here in Northamptonshire. So I'm going to hand over, I think, to Jackie, who's going to go through some slides. Thank you very much, Jackie.
Thank you. Thank you. I'm going to just sort this out. Can you hear me and see me okay now? Thank you. I'm going to use my computer mainly because the screen's behind me, so I can't follow it 100%. But it's been really lovely to have this opportunity to come and speak to you this evening, but also to have a great opportunity to build on a lot of work that we've been building over the last 15 years at the university in Northampton. So the work builds in our university's Dementia Research and Innovation Centre, which I opened and started in 2013. It was a project at that time which brought people with younger onset dementia together to share, socialise and hopefully support each other in a community setting. That was our flagship project, and we've built and built and built on that. You can read about that, those successive community-based early intervention projects that we've been building over the last 15 years. So our centre very much focuses on early intervention. And early intervention is very much about supporting people from early signs of cognitive change. A lot of my interest in this area comes from the fact that I am a mental health nurse. I am still a mental health nurse, and I still practice in the community with people who are living with the early signs of dementia. So I run a number of projects across Northamptonshire and Leicestershire that all focus on this area of intervening as early as we can, to be as supportive as we can, to reduce risk, to identify people earlier so that we can begin to work with them and support them within their own community. So as the title presents, it's about building on our evidence base. It's about bringing science, but doing that in an applied way. So what we do is work with centres, work with different communities and different areas of Northamptonshire, Leicestershire, North Northamptonshire, to look at what is their need. What is their need in identifying people who may be at risk of dementia, but who are also possibly showing early signs, and can we intervene earlier? So that's a little bit about me. It's about where I come from as a mental health nurse. I have a team behind me. It's not just me. We have been fortunate with the funding from Public Health to appoint a PhD student. So we'll have a 4-year legacy of research. She's very much working on, within her own PhD, the well-being of carers, because if you support carers, then you support people who have signs of dementia longer at home. The whole project is bigger than the PhD, though, in terms of The Autumn Centre bit of the whole Orchard project is very much about looking at right place, right time, right care. So right care, right place, right time. So looking at intervening with people as soon as they're showing early signs so that we can help the healthy parts of the brain to re-scaffold and maybe keep them out in independent living for a little bit longer. We're looking at identifying those people. We're identifying at working with them in the early stages. We think our evidence is showing really positive signs that we can keep people out of care for anything up to 2 years longer. The model that we're working on at the moment has come from Denmark. It's evidence in Denmark, and we're building that evidence base here in the UK. We are the only initiative that's looking at teacher-led approaches, and that's not healthcare professions, that's trained teachers working with people living with early signs of dementia as students. So that's the work that we do. It's incredibly innovative, it's incredibly unique. The Autumn Centre's got a lovely footprint. What they've been doing is working with people in those slightly later stages. So that work will continue. We'll look at how we can maybe sharpen that a little bit and hopefully offer within the whole Autumn Centre footprint a pathway of right care, right place, right time, right care. Just to add on a little bit more to that front end, is we also want to work with the wider community to increase awareness around dementia. You know, we're talking about 1 in 4 people over 65 will be affected. That might be family, that's going to be people of working age, that's going to be people who are caring for people of working age. It's also going to be those people who are retired, who are looking forward to retirement together. It's families supporting. It's ever-increasing numbers. That's just because people are ageing longer. So it's good that we're all living longer, but it's more likely that we're going to see greater signs of dementia. So the slides that you have in the pack very much tell the story of the work that we've been doing, the track record that we're building from that early flagship project all the way through to a 2-year project in Northampton called the Unity Den project, to work that we've done in South Leicestershire, to this whole integrated model that we now offer in South Leicestershire and that we hope to work with the Autumn Centre to build on and take to that next level. So we wouldn't want to stop there. This is a sustainable project, so we'll start looking at working with the centre itself, but we want that to be a hub and spoke. So we want it to be a footprint that we can work with other centres in other ways. That's where the orchard bit comes from. So we'll work. It was a slight mistake on my part, and I will forever wish I'd never said orchard and autumn. Sorry, Jane. But the Autumn Centre is part of that much bigger orchard project, where we hope to have the hub and the spoke, working with other centres coming to see what we do and look at the evidence base. So the story in the slides, in the slide deck, very much tells that story. It's something I live with every day, is delivering these types of intervention as a practitioner through lived experience of delivering on the ground those early interventions. So I'm going to stop there. Is there anything you would like me to add? Would you like me to go through the slides in a little bit more detail? Yeah. I'm going to hand over to please. Jonathan to share from the trustees' perspective. Thank you, Chair.
This is completely unprepared. Thank you for your invitation, and I represent the trustees of the Autumn Centre, which, as many of you know, probably all of you know, has been established for 22 years as a community centre, offering for a long time a drop-in service for local older people. Come just before COVID, we were in a situation where we had to re-gear our business as funding was starting to drop out and we needed to be more sustainable. And at that point, we started to welcome people with dementia who were referred by social services because our excellent team have got the experience to deal with daycare at different levels of dementia. And that has been really quite successful. As a community centre, it's facing challenges that many charities and community centres are facing. So the level of funding that was 5 years ago, I think, £65,000 a year in terms of grants, has now been smashed down to 8,000. And in this current year, despite a lot of development, we're facing an £18,000 deficit. So we are looking as a charity business, if you like, at ways not only to be sustainable but to go forward, and the opportunity of being offered the opportunity to become a centre of excellence within this dementia pathway is a very exciting one, very challenging one in terms of what we've done and how we've done it in the past. But the resources from public health and Shirley and the university are most welcome. We are very down to earth. Change is really quite a challenge, but it's a fantastic opportunity, and to be dementia care on the ground, so to speak, is something that we're trembling about, excited about, a little bit anxious because we're not quite sure where it's leading us. But that's what we're doing here, and we're very happy to be partnered with you guys, and thank you for that opportunity.
Thank you. That's a superb overview, and what a superb and great initiative. I'm sure members have many questions, and we're going to touch on a number of different themes as well. But I'll just kick us off. It's something I think you mentioned, Jackie, in the signs. It's about identifying the early signs of dementia in people. What sort of early signs, from the knowledge that you have, what sort of early signs do people show, and also what can we do to stop the rapid progress? And again, this may be part of the research that you're doing at the Orchard Project.
Yeah, so it's a great question. So I think a lot of people typically over the years have assumed that dementia is a natural part of ageing. I think everybody thinks that by the time they get to about 65, that they might be forgetting their keys, you know, as they leave out the door. And if I had a pound for every person that asked me if they were getting dementia at that point, I'd be a very wealthy woman. I think people have to understand with dementia that it's a disease process. And I work with people who are 38 years old, 39 years old. My specialty is those that are under 65. I work with people across the board, but I certainly have a national and international profile in those that are younger. For those that are younger, the signs can be very different to those that are older. So, for instance, they don't have memory problems. I have people who can design logos with pretty moderate dementia because they've always been able to design logos. But their balance or their perception may be off, or their behaviour or their personality may have changed because it's this part of the brain. So, in terms of signs and symptoms, certainly of those that are younger, it's not necessarily, even with Alzheimer's type, it's not necessarily your traditional sign or symptom. For those that are older, a lot of people assume all dementias are Alzheimer's type, and they're not. So, you know, there's quite a lot of different presentation. I think your more typical presentation might be that somebody's recent memory or short-term memory is slightly problematic. And it's not that they forget the keys, they know they've forgotten the keys, but for somebody with dementia, they wouldn't even know that they'd forgotten the keys. There's no process there to forget them, if you see what I mean. They live in the moment. There's also, they show very good and strong long-term memory and working memory. They're perhaps affected much more later in Alzheimer's type, which, as I said, is the vast majority. In vascular, though, you'll get a very different presentation because it depends where the small bleeds are in the brain. So the work that we do very much I will work in later stage, but we do work predominantly in early stage. The earlier the better, so people who are pre-diagnostic, if possible. because if we can work with the healthy parts of the brain, we now know it will re-scaffold a little bit and help people to adjust for longer and stay at home for longer. So thank you for the question.
Oh, thank you. And one other question before I move on to members. Around the project, what specific milestones have been set to track the progress of the project over the next 12 months, 24 months, and how will the projects, and I think you touched on this, integrate with existing dementia care services to avoid duplication and ensure efficiency? You mentioned about hub and spoke, right? But if you can just answer the first question.
Yeah, in terms of the milestones, so we're working on the first 12 months at the moment. We have to have ethical approval to undertake any work whatsoever. So we're obviously doing some preparatory work at the moment. We've got the PhD student in place designing her project. She will go for ethical approval slightly late, at a different time to the whole project. The whole project ethical approval will go in April this year. The end of phase 1 will be completed by the 31st of July. That will include a full consultation with the trustees, the members and the staff. On the findings of that consultation, we will then take the project to the next stage, which is to look at the implementation phase, which will be year 2. So also in year 1, we will be undertaking the community-based workshops, which we are starting to plan now, and we hope will be finished by this time next year. So there is, they are the milestones in terms of the workshops. The workshops will be evaluated. That will be that phase done. We are starting implementation as soon as we've got ethical approval. We're working on looking at which early intervention the trustees and the team and the commissioners want us to look at, and that will be happening in the next year. The final year will obviously be evaluating it and looking at the training that can be delivered from within the project and obviously across the sustainable model as well.
And I thank you. And just to follow up from that, would the Health Scrutiny Committee, this committee, be briefed periodically on?
Absolutely, we have a 6-monthly interim report mechanism.
Wonderful. Thank you. Okay, if I can pass on to Councillor Anslow for accessibility, reducing health and quality scores.
Yeah, thank you. Can I ask a question? What's the difference between mild cognitive impairment and dementia? Is one lead automatically to the other?
No. Mild cognitive impairment doesn't have the same diagnostic criteria in terms of the support that somebody might be offered. So if somebody goes to an assessment, they'll look at the profile and they'll decide whether they go for a brain scan. I'm sure you'll all be aware that you're going to be getting very shortly the new Corby Diagnostic Centre on the doorstep on the 1st of July. So I'm going to be evaluating that. So you asked about the pathway. And the difference between mild cognitive impairment is those people would be monitored without any clear intervention, if that makes sense. And the reason for that is because only 40% of people with a mild cognitive impairment will what we call convert to a diagnostic profile. So mild cognitive impairment is different to ageing in that there are clear differences, but they are not significant enough and may not continue to convert. We're still looking at those mechanisms, and I've got obviously not breaching confidentiality and not in this county, but I have a lady who is under the new trials and testing for the new drug regime that has mild cognitive impairment, and she is being offered the drug to see how it works with the changes in her brain. But the problem we have at the moment is identifying those people early enough so we can intervene early enough. So we suspect that people may be showing changes for some dementia types in their 40s or 50s. So it's getting people early enough from within, maybe even within families where there are risks, and then we can work with them both through cognitive interventions, which is what we're offering here in the Autumn Centre, or eventually we hope through the drugs and the biomarkers.
Thank you. That's really, really helpful to know that difference. I'm starting to use the term with my mother, you see. because she's worried about dementia. I said,
Yeah.
no, it's mild cognitive impairment, don't worry.
Yeah, I mean, some people say it's a diagnosis, and I know some memory assessment clinics do use it as a diagnosis, and then people are recalled annually, but they're generally monitored. What I'd like to do is actually intervene with that group, because we'd like to prevent the 45% from converting.
Yeah, that's what I was thinking. If you've got 45% who will convert, then they're the ones to work with, aren't they?
Yes.
Do you have any data that shows areas in North Northants that perhaps are more at risk? Do you have any
Yeah,
data
we did look at that in terms of putting one of the other reports into a committee. I don't know, Jane, we've not picked anything up in terms of a significant, but I'm only just starting to collect that data at the moment. So I will let you know that at a future meeting.
So the other question I'd like to ask is about the barriers that, prevent people coming forward. We know that there are all sorts of reasons why people don't come forward for cancer checks or whatever. And I think with this particular, dementia, there's fear.
Yes,
real fear.
absolutely.
And it's about reaching out to carers as well. You've already mentioned that.
Yeah.
So what will you put in place, or what are you hoping to put in place to sort of stop those barriers so that people do come forward?
Yeah, so there's a significant problem of different cultures coming through not just in the north, to be fair, across the country. And we're looking at the inequalities in that and what those barriers are. And I think they're probably, I wouldn't want to say similar, but very similar to other disease processes. I think there is something about education that nothing can be done. I'm not sure I 100% adhere to the phrase living well anymore. Certainly that was a big phrase with dementia about 5 years ago. But we can do a lot more to support people in a more positive way if we catch people early enough. So we know that if we keep people integrated in the community, able to work, able to volunteer still, very active mentally, that we can slow progression and delay progression, and also those people stay a lot healthier. That gives carers more time to be educated and to be supported. At the end of the day, it's very often the carers that are keeping those individuals out in the community as long as they are. So it is about working with the two together and strengthening that profile. That's why we want to get to people as early as we can. Identifying people is about much more community education. So again, the workshops will be designed to work with different faith groups, generational groups, business groups to offer that education and to begin to identify the signs and symptoms a lot earlier so that we can intervene. But it is going to be a Hearts and Minds campaign and a lot more of that. And we hope to do that through the centre as well.
Yeah, thanks. So just actually to follow up on Councillor Ansley's point, the points you made about areas, different areas, and I know you answered it in part, but because different habits and different things that people do could influence, not influence, but mean that they get early signs of dementia or they get dementia. So, for example, in more deprived areas, has there been any research done, or is there going to be any research done on that?
Yeah, there's a fair bit of work being done at so one of my roles is I sit on one of the new 4 national dementia networks, and I sit as one of the leads on the prevention dementia network nationally. And we are doing a lot more work with young people at a younger age. We'd like to do at that level, and we'll bring this knowledge into the project. We want to do a lot more work with secondary school pupils. We know we're beginning to see that vaping is probably having a bit more of a detrimental effect on a developing brain, but that science is just coming through. We know from some of the risk reduction studies in Scandinavia that healthy lifestyle, look after your heart, look after your brain, is very good at reducing vascular dementia. We did see a reduction in men after the Healthy Heart campaign of the 1970s and 80s in vascular dementia. And we do know that, again, we're beginning to build a strong profile in our amyloid works and tau proteins in Alzheimer's. And obviously, the new drug trials are showing us a lot more how those processes are developing. So we're not there yet, but we've had some major scientific, doesn't sound a lot, but with the major breakthroughs. And as I say, to also be able to see that that some of our cognitive interventions as well are delaying and slowing progression, and I'm quite excited because I've got some early data on that, which I'm not allowed to report yet, but it's very positive. So we do know if we can work with that healthy brain, that there is likely to be a good response.
Thank you. I'll tell the beetroot juice. Beetroots can help to slow dementia. I don't know if that's nonsense or... but,
I wouldn't stop drinking it. You know, it might work.
Councillor Jackson, please, for your questions on community engagement. Yeah.
I have 3 questions, actually. How are people with dementia, their carers, local community... sorry, I forgot to put it on. Time is bad. Yes, that's one sign. How are people with dementia, their carers, local community organisations being involved in shaping the project's research and implementation? That's question 1. Question 2, what role does the Autumn Centre and other community partners play in developing a dementia-friendly approach, and how will this be sustained? And shall I do my 3rd question? You mentioned early, obviously, you have to get this as early as possible. And you mentioned also that social services is your biggest referral. I would have thought the GP practice services should have been your biggest referral, because they have patients coming through, well, hopefully through from children, etc., through to old age, and one would have thought they would have noticed, or really it's not a question of just a doctor, but obviously the people that they first see, if they forget going to appointments, if they forget to collect their... Surely that should be one of the first signs that you would see.
If I may, I'll take the last one first, mainly because it's not... I don't think I mentioned social services. I think you mentioned that your referrals originally came through social services.
Could I just clarify? Yeah. Yes, it was that for our business, from our business perspective, when those with slightly more advanced dementia are referred, social services will pay a referral fee. And that isn't the first point of contact normally. The pathway is to come very much from a community base, and then to additional help, and then to a higher level of care. And it's that which is supported by the social services. And your question, referring to those initial contacts, absolutely. Over to Jackie for that, please.
Yeah, so what you tend to find, the people who tend to pick up changes in that individual will often not always be the immediate carer, first and foremost. There might be some very minor changes and people put it down to absent-mindedness. It's often, so examples I would give you, it might be a daughter that's lived away for a while and seen a sudden change. Or in those that are younger, it might be work colleagues that see changes in behaviour. The difficulty often is getting that person to recognise that they have a problem, because they don't know they have a problem. So they don't know why they would go to the GP for that problem, because it's not a problem to them. So, and that's not me being flippant, that's just the way their world works with dementia. So the key is to get that person to the doctors, and it would be the GP, you're absolutely right. And then the doctor would do what we call paper cognitive assessments, and would then refer on for a scan. So that they'd look for changes in the brain. So that's the route, that's the recognised route. But it is often the wider community that spots those individuals. So it might be your local church, faith group. It might be, the local Rotary group. Again, I'm a president of a Rotary, and I've got 2 or 3 members in that. So often it's the community that spots those individuals initially, but the key is to get them to the doctors. And obviously then it's getting them early enough, which is often an issue. In relation to your other 2 questions, so we're starting with the Autumn Centre, and obviously we're having project meetings with 3 trustee represented on that, and members. So part of the first phase is a broad consultation across the Autumn Centre as to what their perceived needs and visions are. The workshops are designed to work with the wider community. So we're looking at a fully collaborative and participatory project, both within the centre and much further afield in the wider community through the workshops. And the PhD student, Claire Davis, is going to be looking at working with carers from both within the centre, hopefully, but much further afield in the wider community as well. So we are fully intending it to be a community-based project. Yeah, so the Autumn Centre are, well, Jonathan's here, he can talk for the trustees, but they are fully involved. So the project meetings are the week before each trustee meeting. The trustees feed into the project meetings and vice versa. We're in the process of designing a communication system, which is around a newsletter, and we are consulting with all the members. In fact, the members will be involved in the wider consultation. So at every stage, the Autumn Centre is being consulted and involved, and we are working together through the process.
Thank you for that, Jackie. Okay, Councillor Jenny for the funding and sustainability.
Thank you. Well, my questions relate to the long-term sustainability of the project and future funding. How does the council plan to sustain the project beyond the initial funding period? And what opportunities exist for additional investment and external funding? And secondly, and quite importantly, what steps are being taken to expand the hub and spoke model to other community centres and ensure long-term benefits for people living with dementia, particularly in the wider community?
Chair, are you happy for me to answer the question?
Absolutely, yeah. Please, yeah.
Okay, thank you. So, Councillor Jenny, thank you for those questions. I'm going to hand over to Jackie at the end to talk about future funding, because she runs a similar set of projects in South Leicestershire and has been very successful in getting funding, so she can share with you the type of model that we're looking to support people to be able to deliver. But in essence, the research project will enable us to make evidence-based decisions around service opportunity, service design going forward. It will also enable the centres where people with dementia are supported in North Hants to access this best practice model. So in effect, the services could be shaped to deliver the best practice for the local community. And I think one element you've picked up on in the project is the hub and spoke model. So basically the Orchard project is wider than the Autumn Centre, but the Autumn Centre is going to be the sort of test case, and we're going to work closely with them to develop these best practice activities, and that's the hub. And then those can be pushed out and shared with other centres across the area. And one strand of the activity is, as part of the investment from Public Health, is the university have been asked to help set up a community of practice, if you like. So, and that will be sustainable at the end of the project and self-sustaining. So in effect, it will support anyone else who's interested in accessing the support and information on this best practice model, and it'll create a community of practice so that those centres can support themselves and continue this work. Jackie, do you want to say a little bit about funding?
Sorry, just before that, just on that
Sure.
Point, just wanted to press you further. When would this be implemented in terms of the spokes in the wider area? Because of course Corby's got the centres, Corby's got the research, etc. But when is it going to go to other places like Wellingborough, like Kettering, Rushden, etc.?
Sure. So Jackie talked a little bit about the milestones and the project plans. We will, at the end of year one, we should be starting to be able to roll other activities out. The first year is very much focusing on developing that best practice and seeing what that would look like in conjunction and collaboration with both the staff, trustees and the users of the Autumn Centre. So I think we've got to build that from the bottom up to then roll out that best practice, but we are quite keen to, even if it's about community engagement, to move that on as soon as we can.
So, Chair, just on that last point, one of my other roles is as I wrote the previous dementia strategy and led that, and I'm very heavily involved in the current one across Northamptonshire. So there's a lot of interest in this project, a lot of people who are in the area that are looking to see how this might grow and develop, and we would want to build that knowledge into the dementia strategy group, dementia pathway group. Very much like to showcase this as an exciting flagship project. Obviously, we want to get that footprint right before we roll it out. So we do have to get that base right. But there is a lot of interest. I've had at least 4 contacts in the last 2 months to see if they can come and see what we do. It is a tried and tested model in that we're just finishing this project in South Leicestershire. So we do this. We've done this through a £500,000 lottery grant where we've tested out this early intervention. So over the last 4 years of running that project, we're coming to the report writing stage of that. We're in the process of producing a book as well, which will be out this year. But we have practical example of how we sustain that, and we started through grants. We're looking at a mixed economy of a sort of subscription type membership, but obviously you've got to look at equality of access in that and making sure that funding is available for everybody. So we would look at a combination of grants, some self-payment, and we're moving that model forward. We're also looking at a charity model moving forward. When you're looking at things like gift aid and things like that, that can be very lucrative. We've also done very well with sponsorship grants, legacy, fundraising and donations. So we've sustained that model for around 13 years now in South Leicestershire. So yes, it's tricky and you have to look at different funding streams, but certainly it's much easier to make that funding available if you've got a business case that's based on evidence.
Any follow-ups? Yeah. Councillor Maxwell, please.
So my first question is, how many people do you have at the Autumn Base project? Is it residential or... Because it doesn't say it's residential. Is it residential?
No, it's based on a community centre. So the activities are all day, 5 days a week at the moment. And looking at the figures, I believe there are 900 people that go through the book. So it's not daycare, it's a community centre, and it provides a range of activities. Some people have no diagnosis, and some people have quite a significant level of diagnosed dementia, and it offers support from those people who have no diagnosis all the way through to those that have a significant. So what we're looking to do is perhaps zone the work so that it's a little bit more structured, and obviously offer those early interventions as a new offer. So no, it's not residential.
So does social services actually fund this at the moment?
Do you want me to say a little bit about the budget?
Well, and the current activity.
The funding stream is, well, let's say the annual budget is about 250,000, which supports a staff team of 7 full-time people. We have funding to the extent of now only £8,000. So most of the money comes firstly from those referrals through social service for the higher level care, and then the assisted care, which is a slightly larger number, and then for those members who will come for what we call a daily experience. So they come for a really nice meal, they come for a really interesting program of activities and events, and that's, as it were, the heart, or where the Autumn Centres come from as a community centre. But as I say, with a more focused level of care for dementia patients, clients, people, whatever you call them. But those three levels are really where the main funding comes. And again with donations, and again with occasional grants coming in, and now with this significant level of support from public health to update what is essentially a council property, a council community centre.
So my next question is, so this 199,000, is that a grant from NNC?
Councillor Maxwell, yes, that's from Northamptonshire's capital programme, so it's to refurbish the building.
And is that the same for the 95,000 for this project?
No, the 95,000 is from public health grant, so that's funds the research, which was going to drive the outcomes.
So where does that funding come from, the 95,000?
The public health grant.
Oh, it's from public health,
yes.
Which is separate to the one that we're giving as NNC, is that correct?
Yes, so the public health grant has got quite specific uses, and refurbishment of the building wouldn't be a suitable use for the public health grant. So we made a bid to the capital pot of Northants Council to work alongside this research project, because there are two strands. One, it's the research and evidencing the best practice and being able to use that. But also because the Autumn Centre came on board, we felt there needed to be some investment in the building to make it fully fit for purpose, based to deliver these activities at the end of or through the project and at the end. So you've got those two strands of funding. One is capital funding from the council, and the other is public health grant.
And in any given day, how many people do you actually come to this centre?
It fluctuates a little bit through the week, but it's about 25 people in the main hall on what we call that daily experience. There's probably a further 6 or 8
Up to 8 in the dementia suite.
Up to 8 in the higher level of care, and then probably about 10 on that sort of second tier we call assisted care.
And then can I ask you then, is this just based for the people in Corby?
Practically, yes, because there's transport, obviously. But there wouldn't be a reason why people couldn't travel in from further if they were able to do that. We don't pay transport for people. I hope I'm right about that. There is an element of transport on our annual budget, but I think it's money coming in and money going out at the same time.
It is one element.
Yes.
Can I just ask one question?
Of
the
course.
reason why I ask the question is because transport, we do have transport which can pick up people from Rushden, Wellingborough, Kettering, and that is run on a free basis, actually, this transport, and I just wondered why you weren't using it.
If I can maybe sort of just give a view on that, I think there is something about, certainly in all the projects I've run, we've said if people have been able to get there, we've not discounted them, and we've given a radius as to what that is. I think it's still fairly early days with working with what the Autumn Centre already offers. So we're getting to grips with what the Autumn Centre already offers in order to look at how can we accommodate future needs. So we're doing that work as we speak. And it might well be that the Autumn Centre agree that they can take people from outside, or not, but we're not 100% clear at the moment on that. We know what we can offer at the moment, which is local.
Yeah.
So
Transport is always a problem.
yeah, so basically this centre is for Corby, it's not for anywhere else. That's correct?
I don't think anybody's excluded.
It's
no?
not an exclusive
Is it?
thing. No, it wouldn't be, we wouldn't have a circle round a geographical area.
Right.
I think
Thank
part
you.
of this work that we're discussing is to expand it outwards. Councillor Anslow, is your question on this what's been discussed? Okay, yeah, please, yeah.
Yeah, just a quick question, really. How are you going to measure the success then of the project? Because obviously you've, hoping it's going to be rolled out across Northamptonshire, and I'm sure there are places in Rushden and Wellingborough that would be taking up, hopefully, this way of working. So can you just give us an example of success criteria?
Yeah, so obviously there's going to be monetary evidence. Hopefully the bank balance will look a little bit better. But more importantly, that it's dealing more actively with people earlier. So I think, we talked about the dementia pathway. It's going to be really good for Corby to have the clinical diagnostic centre. Those people are going to need somewhere to be referred to for early intervention. You've already got the memory hubs here, which I evaluated, which came out of my work. So you've got Oakley Vale and Stewart Road. They are incredibly good initiatives that I've also evaluated recently, which came out of my early United M work. And then hopefully this will also show and offer the entire pathway. So we will work across the pathway, and you talked, Chair, about the links in and out of other services. So what you're actually going to have in Corby, which is so exciting, is you're going to have the ability to diagnose quicker, an ability to refer to a centre for very early intervention for those that are needing that, and then you're going to have opportunity for slightly more assisted care within the same centre, and then you've got the memory hubs as well, which are going to be offering a range of early interventions as well. So it's going to be a case of that pathway working out who's doing what, and I'm going to be part of that process. So in terms of your outcomes, it's going to be numbers served, people who are not going into care quite so quickly, people who are not needing as many hospital admissions because they're being picked up, people who are going to the GPs, they might see an increase.
Thank you. Councillor Lawman.
Thank you, Chairman. I sort of work backwards with regard to the transport. There are medical car services, but they are chargeable. That would counter something that people could use, but they work on the 45p a mile, so it's a lot cheaper than taxis, but they're chargeable, so they wouldn't be free. The community fund transport, and I declare an interest because obviously it's on the website, but I'm involved in a medical transport company. The community transport would be free, but you would need at least half a dozen people on it to make it viable, because they use bus passes. So that way. Some of my questions I had have been answered. I mean, I appreciate the points about identifying it early and early intervention, and also persuading people that they that they need to be assessed and finding out what the actual signs are, which is obviously very difficult. But I also take the point about family, where people very close might not notice, but people just that little bit more distance, so slightly further relatives might help. But I have personal instance, and not in this area, I hasten to add, of trying to get a memory test for somebody and asking the GP time and time again, and just not doing it. So the first question is, are we confident in this area that the system is there to get people the tests they need when it's called for? Because that's if you don't get the test, you're never going to get on the pathway. And the other thing, and this is probably for Mrs. Bethia, we've got this 95,000 of revenue funding, and are we confident that if this does get rolled out to other sites, and I can think of places like Glams Hall and Serves, daycare centres and so on, that would be good spokes, if you like, are we confident there'll be funding needed for the future years to roll this out? because it's no good if you find a lot of funding and it just stops, and that's too often the problem.
If I take the first point, and then, so in terms of GPs, certainly for those that are younger, there's a lot of work going on nationally. I'm part of the Young Dementia Network nationally with GP awareness. The problem with GPs is that they see a lot of different disease processes, and they're not always trained in adequately, say, for those that are younger. And there's still a lot of cultural stigma around, you know, younger people don't get dementia, it's always older people that get it. So there's assumptions made of older people getting it and non-assumptions made of people who are younger. So there's a lot of work to be done nationally around awareness in GPs in particular. I know there's a lot of work being done around having staff within the GP surgeries who can do those paper assessments and can pick those people up. But fundamentally, we've got to get that individual to the doctors to be assessed, and that's often where I'm not defending the GPs. I think there's a lot of work to be done there with individual GPs. Some people have more knowledge than others, but fundamentally we've got to get that person there to get them assessed. So, I mean, I work with relatives on a weekly basis who are trying to get their relatives to the GP or trying to get them to groups. And you can't physically put them in the car and drag them there, and that's, you know, you can try. So that's the first hurdle. Obviously, once you've got them there, then it's about making that case. So I've been involved as an advocate, where I've gone in with carers and said, look, I can support the signs and symptoms I'm seeing. We will assess people on the ground. We're not a clinical centre, so we can't do that in South Leicestershire, but we can say, look, these people come to groups and they are showing these signs. We can share that with people's permission. So there is work that can be done, but it's getting people there, but then obviously making a case for those assessments with individual GPs. Obviously, once you get them to the GPs, you've then got to get a referral to the memory assessment clinics to have the scans. And scans don't always show up change. So you can have people that are showing severe signs of dementia who show very little change, and you can have other people who show little change on the brain and who are showing profound signs. So it's notoriously difficult to prove as well. So I'm not defending anybody, but certainly it is a difficult area to work in to get those diagnoses.
So the public health funding aspect of this is for the development of a sustainable network going forward. So it's not there to fund centres to deliver clinical services. It's there so that those centres can develop themselves to become a centre of excellence, but also to make themselves more attractive, essentially. So when Jackie said one of the outcomes we would like to see is a healthier bank balance for the centres that get involved, because we're hoping that it gives people the opportunity to think, actually, we could become a memory hub. We could get people in who are referred to us and become much more self-sustaining, which I think would be really helpful, because it also allows centres to focus on the things they really want to focus on as well. And we do know there's a number of centres that would be interested in this across the patch. Some of them are council ones, some of them are private providers. There's a real mixed economy there. I think our ultimate aim is to say, this is the suite of things that you as centres could do that provide really good care for people with dementia and really good support for carers. There's lots of things you could do. From this, what would you like to take forward? And we will support that through the network, but then we hope they will take that to become much more self-sustaining from a financial perspective.
On that, Jane, so NNC, we're not looking, just to be absolutely clear, fund any actual operational delivery. It's more the education and support in terms of the network.
Not from a public health perspective. The public health bit is about research. It's about, I mean, we hope that we've funded the PhD, for example. So the public health grant, that was legitimate use of a public health grant, is to say, how do we develop the evidence base? How do we get the best possible offer locally? Whatever happens in terms of, I mean, as Jonathan mentioned, adult social care, for example, do refer people to your services. So I would never say that the council wouldn't invest in these services in the way they are doing through adult social care, but the public health intervention, which is quite small financially, really, 95,000 in total, but you get quite a lot for that, actually. You get quite a lot for your money in terms of supporting other organisations. There's also other things that the council have done around things like infrastructure costs, infrastructure support. So we know, for example, that the council have invested in a service really that allows organisations in the voluntary community sector to get some support about how they get grants coming in, how they get money coming in. So the council's got lots of different things it could do in that space. I can't speak for adult social care, but they do obviously refer people to services like this. We want to make it a really attractive place for people to be referred to, so that centres like the Autumn Centre become really self-sustaining, have a really healthy, sustainable future in terms of what they provide.
Councillor Lorman.
Just as in, say, smoking and education and information would count as public health facilities, though, wouldn't they? So even in this area, so yeah. So that's an area that
this is today. One of the really exciting things that Jackie hasn't mentioned, it's in the slide pack, and it's funny you should mention, I have to mention it now you've said education, is so one of the projects that Jackie runs, actually, is at a school in Lutterworth, so Lutterworth College. And that is, I think, personally, a fantastic piece of work, and something we've talked about, isn't Jonathan, at the meetings we've had about how do we get younger people through schools, for example, getting more involved in understanding what dementia means. Some of the stories Jackie's told me about the pupils working with the members of your centre and what they bring to the members, but what the members, more importantly, in lots of ways, bring to the young people is fantastic. We could just do a whole session just on that. It's wonderful. And that's something we'd want to do locally, because actually there's a whole range of things that come with that. From my perspective, one of those things is we will attract more young people to go into social care type roles where you can make a massive difference to people. I mean, I've met some of the volunteers and some of the young people who are in training or at the Autumn Centre, and they're just fantastic, aren't they? And we need more people like that. So getting the schools involved, getting the colleges involved, kind of essentially stealing with pride the Lutterworth College model, I think could have fantastic implications for our local area and for our young people, and bring the people we desperately need into social care.
Thank you, Jane. Superb debate. So one final question from Councillor Maxwell.
What I can't understand is why the NHS is not involved in actually bringing this service on board so that it's right across Northants Council, not just certain areas. And so I would like to see the NHS be a lot more active. And regards to younger people, which you just mentioned, I think one of the issues is that the courses which would relate to this, which could be done in schools, was actually cancelled some time ago, and therefore that's one of the reasons why young people not necessarily being involved in it.
Yeah, Jade, please. Yeah.
I think one of the things that I really love about the work that Jackie does in Lutterworth is that there isn't a course that works with the members. There are so many different parts of the curriculum that are engaging with the members. So it's not a case that there's a group of young people doing an adult social care course. There's groups of young people. I know that there's some fantastic future chefs, for example, who are preparing food. They're working on the menus with the members, and then they're delivering the food to the members and getting feedback. And it's just a really fantastic way of delivering that kind of teaching. And one of the things Jackie said to me, which has really stayed with me, is about the young people walking past and walking through Lutterworth, who have now started to stop and chat to people when they wouldn't have stopped to chat before. And some of that community stuff that's coming out of that, I think is fantastic. Did you want to mention the NHS piece?
So if I can, if that's okay, Chair. So
Yes, of course.
one of the things I would love to do is involve the NHS much more actively in early intervention. I think the issue with that, I think we have that. Northamptonshire generally has been very, very early adopters of all of the projects that I've initiated, and actually has been showcased to members of Parliament fairly recently in a curio activity. So, you know, we were selected as the second county, North and West, because of the work that we've been doing with early intervention. I think there's something for, and I'm going to maybe be slightly provocative here, but it's actually true. There's a lot more work to do for the government to actually swing some of the health money into early intervention and prevention. I think the government's in its comorbidity strategy coming out is very much focusing on prevention. I think we need to, and it's absolutely phenomenal that the North Council has invested in prevention, because I do think it's the future, but I think it's because we're an early adopter here, and you're going to see much more of the country challenging to have more money coming in this area.
Wonderful. Thank you very much, Jackie. Wonderful discussion. I'm just going to sum up with one main recommendation, one that was alluded to earlier. So this committee recommends that a structured evaluation framework be established to assess the impact of the Orchard project, with regular reporting on key outcomes such as dementia awareness, service accessibility and participant well-being. And you mentioned about 6 monthly updates and briefing to this committee. Thank you. Right, on to the next item. Get to it, the disability, disabled, apologies, facilities grant. Amy, do you want to present this?
Thank you, Chair. I've circulated, well, the report's been circulated, so that outlines DFGs and delivery and current implications and actions. But I thought I'd present a bit more information by means of a PowerPoint. So I've not been along to this scrutiny committee before, so thank you for inviting me. So starting from the beginning, in terms of disabled facilities grants, they are mandatory grants that we provide vulnerable disabled residents across North and Northamptonshire that are eligible. The various adaptations include providing grants in terms of allowing and providing access in and out of the property, making a property safe, giving access to the family bedroom, the family rooms, the bathroom, the toilet, and making modifications to kitchens, sometimes providing heat, light and power. So this is a mandatory requirement that we do under the Housing Grants Construction Regeneration Act. Under the Regulatory Reform Order, we have discretion to be able to do a lot more, which is what we've recently done by means of the new policy that we took forward to Executive in January. Next slide, please. I focused this report purely on 23-24 data because that's the last full year set of data that we had. So since vesting day, we've been allocated just over 2.5 million. And for 23-24, we spent 2.3 million, just over 2.3 million. The allocation for this year has increased to 2.7 million, and so far to date, we've spent 2.2 million. The mandatory grant is £30,000. The discretionary top-up was 10,000, but we've recently extended that to 20,000. So the maximum grant available for an adaptation is £50,000. Next slide, please. So for 23-24, the total number of occupational therapist recommendations that we received for North Northamptonshire was 544, and we completed 254 grants. At that point in time, there was 55 grants on our waiting list. Figures for this year, we've received 381 so far, completed 183 grants with 53 grants on our waiting list, but we obviously haven't got the full year yet. In terms of the structure, I just thought I'd outline my service area. I'm the head of service, and I've got 3 operational teams. The team on the left is the Disabled Facilities Grants team. We have the DFG manager, 4 surveyors, a senior surveyor, which is a post out for recruitment at the moment, a DFG technical officer and 4 grant support officers. I've just completed my permanent restructure, so that's what it looks like. The other 2 teams, standards and operations, that focuses on other private sector housing issues around landlords, HMOs, empty properties, tenant complaints and enforcement, so I won't talk about those this evening. I also have an energy officer on a fixed term contract. I thought I'd just give you some photos throughout this presentation to showcase the good work that the surveyors do. So this is a single-storey bedroom extension with a level access shower that we provided a couple of years ago, which helped a person who was no longer able to get upstairs to their property. I thought I'd now focus on the new policy itself. So we took a paper to executive in January, which outlines the changes with the private sector housing assistance policy. It explained that the discretionary top-up had increased from £10,000 to £20,000. The other key change was that we're no longer going to means test for certain equipment cases up to a maximum of £10,000. So that will include things like stair lifts, ceiling track hoists, and any other DFG-funded building works as part of a larger scheme. We will not be placing land charges on schemes such as 3-floor lifts or stair lifts or any amount below £200 because it doesn't really add value. The purposes of us putting land charges on grants is to ensure that we could recover our money should the property be sold after a period of time when they've received the adaptation. What we don't want to do is provide all these grants for people to then move house and not benefit from the adaptation. So that's why we put land charges on the property. The 4th change that we've introduced is being able to fast track certain DFGs. So currently we have recommendations that come into us from the occupational therapist, and they are graded either critical, urgent or standard to help with those more urgent cases where there's hospital discharges or terminally ill cases. So by introducing the fast tracking, we are now formally able to fast track those cases that don't fall under standard, urgent or critical, but they are terminally ill or need palliative care. We weren't previously able to do that. I've just included a few more photos here. Here's a double extension that we provided a few years ago for 2 children that were heavily disabled in wheelchairs. We provided access to the garden, a 3-floor lift so they could get from downstairs to upstairs, and ceiling track hoists. This second photo here is another single-storey extension for a ground floor bedroom, level access shower, and also it provided a ceiling track hoist and an external step lift for this child that was in a wheelchair. Here's a picture of a 3-floor lift, again a child's application, which shows the 3-floor lift coming up from the ground floor into the 1st floor bedroom. Not too intrusive, as you can see, but it very much has made a huge improvement to that disabled child's life. Moving on then to the further changes that we've introduced in the new policy. Talking about dementia grants, we've now introduced dementia grants to cases that are over £1,000. So we've not been previously able to help these people at early diagnosis stages. By the time we provide a disabled facilities grant, it often can be too late in terms of the patient's diagnosis has been quite further on down the line. By providing early interventions when we first get the diagnosis, we can put simple measures in such as safer flooring, labels and signs, contrasting colours in the bathroom, which often helps them between navigating their way around the property, installation of contrasting coloured fixtures such as grab rails, toilet seats, lighting in bathrooms and kitchens, and assistive technology. Here's another picture here of a shower stretcher and a ceiling track hoist for a patient that's able to now have a shower with dignity that wasn't able to before. Here's some examples of adaptations that we provide for those that may be visually impaired or that have dementia, that can see the contrast between the tiles and the equipment in the bathroom. So continuing with the private sector housing assistance policy, the 6th change that we introduced was helping people with motor neurone disease, something again that previously wasn't focused on in the old policy. but we've now introduced this again by providing it early doors by means of fast tracking. So there's no means test for the cost of works up to £5,000. We would ignore the applicant's earnings. Often people with MND still are able to work and carry out a full-time job, and for those that understand about the disease, it does I think I've got my other hat on. The patient's condition can deteriorate quite quickly, so it's important if we can help these people early doors without the needs for a means test. We can actually provide those simple measures to enable them to live in their properties before the disease escalates. Another part of the policy that we've changed is by introducing an independent panel. With the cost of materials and the cost of labour nowadays, often more complex adaptations such as ground floor extensions or converted garages often cost over £50,000. So it's important that we get independent decision making on cases that go over the grant threshold. So we've set up the independent panel, which will be made up of the assistant directors for children's services and adult social care, and our portfolio holder, Councillor Rowley, sat next to me here. This panel will review those cases, and they are ad hoc that come forward, and they will make independent decisions on cases where we do need to spend more than £50,000, subject to evidence that I would have to present in terms of medical evidence and the financial status of the family concerned. The eighth change that we made to the policy was around equipment. We previously provided a warranty for 12 months, but we've now extended that to 5 years, again to allow disabled people to not worry about call-out fees or repairs to the installations that they previously had installed. Sadly, stair lifts do go wrong, they do break down quickly, but they're perfectly fine, they just need a quick repair. So by extending the warranty to 5 years can enable disabled people to have their stair lift usually repaired in a timely manner, as opposed to having to wait weeks and weeks and find the funding themselves. The ninth change that we made was to work out how we could tap into private landlords and housing associations. Disabled facilities grants are provided cross-tenure, except for council house tenants, but we do find with private landlords and housing associations there has been delays in the past with them, so we are trying to streamline that process. So if we can get the private landlords or the housing associations to work with us in some way, whether that's to either manage the work themselves, do the survey, find the contractors, then we can streamline their cases and take them away from the waiting list that we have in place. Some more final photos here of some external step lifts in a property. And some more pictures here of some outside ramps and wide steps to enable people to get safely into the front of their property. And then the final change that we've introduced in the policy is to cover non-mandatory works. So most mandatory works is around access into the property. As I said, kitchen modifications, bathrooms, level access showers, step lifts, ramps, etc. But with more and more complex situations coming forward to us now from the occupational therapists with situations such as ADHD and children with behaviour problems and complex medical needs, we often find, and we've often been told, that work such as providing a sensory room or a safe space or a formation of a safe patio to enable people to get access to the gardens, treatment rooms, ramps for scooter access, it goes a long way to help that person remain living independently and with dignity in their own property. So this is a mandatory works that we have to provide under the legislation, but we find that these generally low-cost measures, this non-mandatory work, does go a long way. So anything under £1,000 will include within the scheme of the mandatory works, but if anything goes over £1,000, we'll take it to the independent panel to get that independent decision made as to whether we should go ahead with those works or not. Drop curbs and hard standings are quite a popular one actually for that access. Another photo there of a drop curb and a hard standing there, which has been successful for that family to be able to safely get into their property from the car off the pavement. And that brings me to the end of my presentation. So that's a sort of whistle-stop tour of disabled facilities grants. If you've got any questions,
Wonderful.
Please, happy to answer
yes.
them.
Thank you very much, Emmy. I'm sure we have plenty of questions, so That slide's quite relevant. Any questions? So you have answered some of this. You mentioned about the 50k. I was going to ask what would be the process of if it's more than 50,000. What's the process? But I think you've answered that. It gets brought to. If you can just further elucidate, if that's okay.
That's right, yes.
Yeah.
I mean, obviously, people have to be eligible first. I probably didn't touch enough on that in my presentation. Obviously, these grants are provided to financially vulnerable people. So people on certain passported benefits will automatically qualify. Anyone else is means tested. But in terms of the threshold, yes, anything over 50,000 would go to the independent panel.
Yeah, and do you have any headline data on the fast tracking and the reduction of the means test requirement? Have you noticed any change in the time it takes to complete an application from?
So the policy's only just been approved by exec in January. So in fairness, we've implemented it now, but we haven't actually utilised the fast tracking yet. What I can say is all the occupational therapists' recommendations that come through to us every month are already graded in terms of critical, urgent or standard. So critical cases are usually allocated to a surveyor and dealt with in terms of starting the process within 4 to 6 weeks. Urgent cases are within 3 months, and then standard cases are started within 12 months. We do get a high volume of inquiries and a high volume of recommendations, and I've currently got a team of 4 surveyors and 4 grant support officers, so we do prioritise them. But no one is waiting for longer than 12 months for their grant to start. The fast tracking will be for those that need. We've always fast tracked people that are desperately to get out of hospital or end of life care, because we need to get on with those straight away. But this policy's formalised our ability to do that.
Yeah. Sorry to pick you up on that, and thank you for your answer. But I do have, I think, 2 constituents. I think 1 or 2 constituents that have waited for quite a significantly long time.
Oh, right.
More than 12 months.
Oh, really? Okay. Please give me the details of those. Bearing in mind, start to finish can take longer than 12 months because of planning permission. So that we start the case within 12 months, but it might take longer than 12 months to complete. Yeah. Just to clarify that, but if there are cases, then do let me know.
Thank you, Councillor Wright.
Yeah, just to extend on that a bit further. So it can take 12 months to get the application processed, but then we've got planning permission, and we all know how long sometimes that can take to go through. We've also got the challenge of contractors to actually do the work. As we were talking before the meeting, we've got a finite number. Amy's trying to extend that portfolio. The applicants can find their own developer if they want to do that to speed things up, but it's trying to get builders and workmen to actually do the work as well. That's one of the stumbling blocks we've got that we're desperately trying to sort out. But it's if you try and find a builder these days, you're always waiting months because there's a shortage of builders. So.
Yeah, and I heard from you briefly, actually, before the meeting, but just on that, in terms of contractor shortages and ensuring value for money in the procurement as well, do you want to further explain what we are going to do to rectify this issue in terms of contractor shortages, so we can reduce waiting times?
Yeah, so we have a pool of contractors at the moment, so it takes a number of months to validate the application. We then approve the grant, there's then planning permission, and once we've awarded the work to the contractor, they might not be able to start for 4 months, so that does put in another delay, but we're trying to find more contractors so they can start on site sooner. So obviously we're going to update our procedures, and when we start, when we implement the new procurement framework for new contractors, we're going to be expecting them to start within 4 weeks ideally. Now that's going to be a challenge because not all contractors can start within 4 weeks, so we need to widen the net and look further afield. There is a platform called Diversity, which I'm working with at the moment with foundations so that we can bring in more contractors from further afield. We prefer local contractors, but often they can't start for 4 to 6 months. So if we look further afield with Diversity and implement that framework, which is kind of an alternative to the dynamic purchasing system, which I'm also looking at along the same side, but legal and procurement colleagues tell me that the cost and the time to implement that will be lengthy. So this alternative installers network, it's called, with Diversity, is a quicker way to get new contractors on board. So I'm doing the prep work at the moment, and I'm hoping to get that implemented in the next few months.
I'm going to get other members in after one final question. I've got other questions, but I'll let members have the opportunity in a moment. Just want to know what we're doing to ensure that residents are aware of the DFG. What's the awareness campaigns like?
Well, we don't proactively advertise DFGs because people within our network in terms of health and GP surgeries, members, residents, they do know about it. It is heavily featured on our website, but most doctors' surgeries and health professionals, occupational therapists are aware of disabled facilities grants. So through those stakeholders in itself, we are not short on inquiries or demand. I mean, there are going to be sad cases and situations where residents perhaps are living in sad situations and aren't receiving any help. So I do rely on the eyes and ears of the community to help me and get complaints from residents, members, ward members to say there's someone here that doesn't have a ground floor toilet, so we can reach out to them as soon as we can. But I do rely on the community and stakeholders to share their intelligence with us.
Absolutely.
But most disabled residents do come forward, so that's good.
Yeah, thank you. Can I pass it on to Councillor Jenny, please, for accessibility?
Thank you. My questions are again centred on accessibility and equity of service for all. Firstly, how does the council ensure that the disabled facilities grant are accessible to all eligible residents, particularly those in rural and underrepresented communities? And secondly, what steps are being taken to support residents who may struggle with the administrative side of the application process?
Thank you, Councillor Jenny. So in answer to your first question, in terms of accessibility and equity of service, so it is provided for all residents that are eligible. And in terms of reaching out to those in the rural areas, obviously a lot of our communications are through the telephone and online. So for those residents that don't have access to the internet or don't have access to our services on our website, I'd hope that they would call into the council, or a referral would come in from a GP or from an occupational therapist, and we can process their application over the telephone if need be. It doesn't all have to be online. There is a lot of administration involved in terms of the second part of your question in terms of the application form itself. We always ask the applicant if they've got a next of kin or a reliable neighbour or trusted friends that can help them with the application. But there are situations where people are vulnerable, are isolated, are out in a village and that have no support at all. So we would send one of our grant support officers out to the property and do it with them in the property itself if need be. That would be the last resort. But most people do have a next of kin or a reliable friend, neighbour that can help them with the process and we can utilise them to help with the process. Thank you.
Sorry, Chair, if I could just add a little bit more. In terms of the equality and accessibility of the grants, obviously, unfortunately, council house tenants can't apply for a DFG. It's just the rules of the system. So we can't use our own this funded money. So we have got a pot of money in the HRA account for this work, but it's a lot smaller than the DFG, unfortunately. So we do make it so it's as equal to everybody. If they're in a council house, it may well be that the other option is to see if we can move them into a housing association where they can get the DFG and probably do it quicker than through the council houses. But it will always be with the agreement of the tenant. It won't be forced on the tenant that they've got to move to get that modification to the house. It may be it's a better option for them, and we'll help them with that as well.
Thank you, Mark. Okay, Councillor Anslow, please.
I didn't realise that. So the housing revenue accounts for Ketchum and Corby, do they have, money in there, capital money that they're able to use for?
There is a pot of money in the HRA budget for adaptations, yeah.
But not enough, maybe.
It's not run out yet, but we have gone to the limit of the budget. Obviously, with the whole of the HRA budget, if there's an extra £10,000 needed, and there's another pot that's 10,000 light, they can move that around. But there is the pot there that we can do the adaptations. And like I said, it may well be the resident and the housing team come to a joint decision that a housing association might have a house with the adaptations already done, so they can move into that. We might have a council house that's got the adaptations that they can move to as well.
Thank you. I'm learning a lot. Yeah, I was going to ask about some of the figures, actually. Where are we? The number of recommendations this year so far was 381, and the number of grants completed 183. And then you've got 53 on the waiting list. So there's a number there, isn't there? Are they just not allowed? Is it those people decided not to go ahead, or?
We haven't got to the end of this. You talk about this current financial year, 20. A lot of grants do get. I mean, obviously, DFGs run across financial years, and actually, as it happens, a lot do get finished between January and March, and we're always quite keen to spend the allocation with any financial year. So a lot will be completed now until the end of March, and obviously these figures don't include February's. These just includes January's data. So a lot will get completed in the last quarter of any financial year. But a lot of complex schemes do often run over 2 financial years anyway. So it's probably useful to look at a 5-year plan in terms of numbers, because the numbers do fluctuate, and there is a drop-off rate where some people change their mind, or sadly the resident dies halfway through the process, or people apply and then there is a financial contribution they have to make, and they decide they don't want to pay that financial contribution, so they drop off. So there is a drop-off rate of about, the drop-off rate between 40 and 80 cases a year, as many as that, sadly. And it's often because they've changed their minds, or they don't want to pay the financial contribution, or they weren't eligible in the first place. But the number of OT recommendations, it was interesting, if you go back a few years before NNC, the number of OT recommendations has been increasing year on year on year, as we're seeing an ageing population and people living longer, which is fantastic. But actually in the last couple of years, it is starting to even out a little bit. So it'll be useful for me to come back at a later date and give you the figures for 24-25 to compare it to the previous financial year.
And you talked about the increase in non-statutory as well, which the OT would be putting forward.
And with the new policy, we will probably be providing more grants anyway, which may or may not skew the figures in terms of what we're providing, but the overall trajectory, I'd like to think, is positive. We're spending the budget and we're helping ultimately more people live independently, keeping them out of hospital, keeping them out of care homes. You know, that's our overall aim.
Can you explain to me about the no land charges? And is it paid back? Is the grant paid back if it's a private housing grant, did you say, or not?
It's only paid back if they breach the conditions. So obviously what we don't want to do is spend £50,000 on an extension, which has happened unfortunately in the past, many, many years ago. You spend all this money on an extension for a disabled child, and it has actually added value to the property, and then they decide to sell up and move on, and they've obviously enjoyed the equity out of that property in the sale of the property. So we've always put land charges on grants for expensive builds, because it's our way of saying, you know, we're investing in your property and for your family to enjoy the adaptation, but we also want you to stay in this property. But should you sell up for whatever reason, they might want to move away and live with other family, then we will recover the costs through the proceeds of the sale of the house. So that's why we put the land charge on the property. But for things like, the change here is for things like through floor lifts, stair lifts, they don't add value. If anything, they probably cost more to rip them out afterwards. So through floor lifts, stair lifts, hoists don't actually add value, but it's more the extensions. We don't want people to sell up after we've just given them an extension.
No, that's what I was thinking.
Sorry, just on that point, the land charges, is that time limited?
So 30-year condition, yes.
30 years.
Yes,
30 years. Okay. I wanted to ask about, it's good to hear that you're finding ways of improving the number of contractors. Which is the question I wanted to ask. So in a way, you've answered that question, because you've talked about the way that you're going to use a wider pool?
We
of
want to
contractors?
access. It's called the Installers Adaptation Network.
Yeah.
It's a platform that foundations which govern home improvement agencies across the country. They're the ones we've tapped in. We've given an expression of interest. We're just waiting for access to this network and going through the correct procurement channels, and then we can reach out to all these contractors. At the moment, when we send tenders out, we send it to our known contractors on our own register. Residents can use their own contractors if they wish. They might have an uncle so-and-so that's a builder. We try not to encourage too much private contractors. People are allowed to, because we know our contractors do a good job, and it's quite specialist work, some of this work. So we know that our contractors do a good job, are value for money. So when someone says, well, I've got a relative that can do the job for me, that's fine, but we'd want to put them through certain checks to make sure the family aren't going to get ripped off, and we're not going to pay too much on the grant. But once we've got access to this wider network, it will allow us to get more grants delivered quickly. That'll be good, in a more timely fashion.
And it's also good to know that you've increased your staffing capacity.
Yes, absolutely,
That's obviously
and we still can.
Through.
I mean, that's the added benefit. I mean, obviously the allocation's been increased already this year from 2.5 million last year to 2.7. So this is my testing year, really, because obviously from vesting day, for the first 2 years of NNC, I was dealing with a lot of backlog from Wellingborough, Kettering, all the 4 councils. Each council presented me with a big backlog of cases, so we've cleared the backlog. We're nearly on top of that now. So this is my sort of benchmarking year to see how many grants we can deliver in a year against the budget that we've got available, against the demand that's presented to us. And obviously I can then future plan for the future then in terms of, do I need to bring in more surveyors and more grant support officers? For now, I wanted to try and deliver with the staff I've got available. We have got 1 senior surveyor advert out at the moment, but if we need more staff, we can bring them in because it's paid from capital, so it's not impacting on revenue, which is great.
Thank you.
Thank you, Amy. Councillor Jackson, please. That's you. No.
I have 2 questions. What further innovations or digital solutions could be implemented to improve efficiency in a DFG application and processing system? Question 2, how will the Council evaluate the success of the policy changes and ensure continuous service improvement?
Okay, so if I start with the first, I'm just writing it down so I remember continuous improvement. Okay, so in terms of the first question, in terms of innovation solutions and how we can be more efficient, I don't know if you had an opportunity to read the full policy, the new policy in full, but the measures that I outlined today on the presentation does talk about how we can fast track and make improvements, because previously we were obviously working under 4 different policies, and then obviously at vesting day we worked against 1 policy which we hadn't had the opportunity to update. So this new policy does give us that scope to implement some fast tracking. So for those residents that do need urgent care, we can formally fast track those cases now and assist those residents that need to get out of hospital quickly or that are terminally ill. In terms of solutions, I am working quite closely with Laura Sinclair, the head of therapy, and looking at assistive technology and looking at new ways of how we can look at new technology and new adaptations to help the growing number of adults that we're seeing with more complex medical needs. So we're constantly reviewing and evolving what adaptations and equipment and solutions are available, and obviously the surveyors are very much connected to networks on, again, different practical solutions that they can provide in terms of builds. There's different types of specialist toilets available nowadays. There's different types of alarm systems to get people safely in and out of the property. So we're always reviewing what equipment and provision is out there that we can use. Does that answer your question for that one? And then the second question in terms of evaluating the process, obviously evaluating the success of the policy. So the policy's only come into fruition recently. It was only approved at exec in January. I'll be reviewing it at the end of the year and probably reviewing it quarterly throughout the year in terms of looking at numbers of grants that we've approved, whether we've used any of these discretionary measures. And certainly by the end of this the next financial year, I'd like to put together some stats on how far we've gone in utilising these discretionary measures to make continuous improvement.
Just to add on that, the policy was to answer your first question, the policy, as Amy said, the policy was specifically written to get rid of as much red tape as we could.
Yes.
To speed up the grants, but it also meant that officer time was reduced per case, so they could do more cases in the same time. And one of the biggest criteria for me, being really crude, is if we've spent the money and everyone's got their grants installed, then that's a big win for me. We've got quite a bit of money that hasn't been spent, so we've widened the scope on the policy to include a lot more non-mandatory grants to get more people into the system so that we can help them, make sure they stay in the homes longer and have a good quality of life and spend the money. So if we've spent the money and we've got the grants, all of the grants through, then that's a big bonus for me.
Just on that, are we going to establish the framework for budget carry forwards, so we can spend the money that's not been spent yet? It's remaining.
It's already in place.
It's already in place.
Yeah.
In place.
It's been in place. It's been in place since vesting day.
Right. Okay, Councillor, who have you got a question? Yeah, Councillor Lawn.
Thank you, Jim. Just a couple of quick things. On contractors, it seems like every 2 minutes I get something in my social media feed about somebody who can do minor works. And they're always available. But one thing I think was just said that applicants can get their own builder, if they like. So is that something that you actively promote to people when they apply, to say that they could get their own if that's short circuits, because obviously you haven't got to go through the procurement exercise. But the other thing, I'm slightly confused. In the paper, you said, and you just said it again, there's no backlog. But when we look at the information on page 48, it says last year 544 recommendations received, but only 254 grants. That's nearly 300 different. And then this year, it's almost exactly 200 different. Yeah. So what's happened with the recommendations and the grants? Are people not qualified? Are people doing their own thing? Why the big difference?
Okay, in answer to the contractors, we don't actively encourage and promote residents to bring in their own contractors, only because of bad experiences we've had in the past where there's cowboys, for want of a better word, people coming in that don't know how to do the job, electricians, builders that don't know how to build, and it's unsafe, and they run off on site because they haven't got enough money to finish it. So we like to use our own contractors that we've vetted and we've approved, so we know their job's going to be done properly. But people can still use their own contractors. We just, with this new process I'm looking at with diversity, we need to work out a way of how we can vet them first and check that they're compliant or on the construction list line.
Don't pay them till they've paid.
Well, we don't pay them. We don't pay them anyway. No, but what often happens is one builder will start on site, do a run, and then we have to pay someone else to pick up the pieces, and it's finding a builder that wants to pick up someone else's work. It can get complicated. But yes, in answer to that initial question, try not to advertise it too much. In terms of the figures, when I referred to the backlog, this was the backlog figures that I've referred to previously is the figures where people hadn't even sort of made it to the waiting list. So we'll always have a small waiting list. So as grant applications are validated, they are then put on a waiting list to be allocated to a surveyor, and currently it's 54. And there was previously a backlog with the OTs as well. So there's no longer a backlog with the OTs. I think there's a 12-week wait again to get the assessment. So it's that backlog that's no longer the case anymore. Are you referring to section 5.21 when you mentioned some figures, just so I'm clear on what figures you're referring to?
It's on the slides.
On the slides there.
On the slides here.
Page 48 in our pack.
Oh, I see that. So the gap between the OT recommendations and the gap between the grants. So the number in between will be worked on at the moment. They'll largely be jobs on site, jobs in the process of getting the application validated, waiting for planning permission. So it's everything in between the referral being received and the completion sign-off happening. So those figures will increase by the end of the year, the total number of grants completed for this year.
So they're the work in progress jobs. So 24-25, there's about 150 work in progress.
And bearing in mind, and because grants they're transient across financial years. So last year, yes, We had 544 OT recommendations and we completed 254. Those 544 were probably included in the 183 that have been received this year, and the 381 that we've received the back end of this financial year will probably be completed in the next financial year. Do you see what I mean? It's a moving ship. What we receive in one year, we don't necessarily complete in that year. The numbers, they do catch up with themselves, but you don't get the same numbers in each financial year. I think what's key, I've thought about this long and hard in terms of various performance matrices you can think about. It's ensuring that no one's wasting any length of time. That's how I want to look at this. And I look at the number of referrals received each month and the number of completions each month. And, you know, it's just ensuring that there is no one waiting for too long.
The way it's put down, it rather looks as though you're refusing people, but I mean, I'm sure you aren't.
No, we're not refusing people, no, and I have got those figures as well. There is a drop, I call it the drop-off rate. There is a drop-off rate where people pull out at the last minute, often change of circumstances, people move away, sadly the client dies, they don't want to pay their financial contribution. There are a number of reasons, they move house, there's a number of reasons why they pull out halfway through the process as well. But we don't reject any applications. They're either eligible or they're not eligible, and if they're eligible, then we'll take them through the process.
Wonderful, thank you, Amy. Councillor Maxwell.
Well, my first question is, you say that you have just 4 people for the whole of, is that for the whole of Northants?
4 surveyors and a senior surveyor, yes, not many, I know, they work hard.
Yeah, but we're not employing any more.
We could do, like I say, this is my benchmark year. We do have 4 grant support officers as well and a technical officer. So between the team of 10 with the manager, they deal with that throughput of numbers at the moment. So I will be evaluating this year's activity and making a decision if we need to bring in more surveyors to get more things done quickly. But the more we spend on staff, we've got to weigh up against what we've got left to spend on the actual grants itself.
So how many admin staff do you have who actually look at the
4 grant support officers. Just 4? 4. So it's the way it was designed, it was 1 from each area. We're harmonised now. We work across Northamptonshire, but the way it was brought together was it was 1 from each area. So previously under the legacy areas, it was just 1 surveyor and 1 grant support officer from the 4 areas previously. That was all the resources that were available. So yeah, it could be argued it's depleted. But we managed to deliver with the figures that I've presented you tonight.
Do you not think, well, I mean, don't get me wrong, but I'm just thinking with the population increase, which there is in this area,
and houses, I'm expecting
population increase, you know, you're going to get more applications.
I'm expecting to, and as the number of, we're building more houses and the population is increasing, so I'm expecting to grow, and I will be growing the team over the next 18 to 24 months, but it's really difficult to recruit some of these positions. There is a lack of trained professional staff, unfortunately, to do the work. We have had vacant posts for a long time, but we're at full incumbents now, near enough. So this is my benchmark year to see what the current team can deliver with the throughput that we've got. And obviously, I'll increase more next year if we need to. That won't be a no. That'll be something I'll need to explore.
So Amy's just done the reorganisation that's just been approved. So the levels at the moment, without putting words in Amy's mouth, are this is the level that she needs to do the role at the moment. Obviously, we know that the population's getting older. We've got more houses, although the more houses doesn't necessarily mean the grants are going to be impacted. It's the disability grants that are required. So as that increases, then Amy, or it might decrease, we don't know, but I doubt it, then Amy can flex her team by going to the relevant approvals team to get those readdressed to match the needs moving forward.
One of the questions you said one of them on a fixed term contract. Isn't that more money? Doesn't that not cost us more money?
That was the energy officer on a fixed term contract.
Right. The other thing is, I've been dealing with a person, or a couple actually, in Earthling Borough, and one of the issues has been that they initially had to pay towards the having the alterations done, but the actual bungalow belongs to a housing association, which I find a bit strange that they were having to pay for this. So where you got a housing association owning the bungalow, surely they should be investing in that change for that couple. So what happened in this case was a bathroom where the gentleman could get into the bathroom but couldn't shut the door to go to toilet, which was a bit embarrassing because in a bungalow, as you know, you only have one entrance in and one entrance out. So, but the fact was that they didn't seem to actually understand, the housing association, that it'd been better actually to have actually moved them. So is that not a thing that you take on board?
Yeah, unfortunately with the DFGs, the grant is awarded, and if there's any surplus requirement, someone's got to pay for it, and unfortunately NNC can't. So ideally the housing association would do the pay the additional money, but some don't. So unfortunately it's down to the resident to actually pay for those the additional payments themselves, so that they'll get up to £50,000 on the new scheme. If it's 55, then that 5,000 has got to come from somewhere else. It can't come from NNC, unfortunately. So a lot of the housing associations will look at it and say it's an investment, it improves the quality of the residents' life, and will pay for it. Unfortunately, some don't, and we can't control that bit.
If the person happens to be on a fixed income, that actually makes it very difficult, doesn't it?
It depends. I don't know if you're talking about a financial contribution maybe. So sometimes there's a financial contribution to make by the residents. So we carry out a means test on the applicants. And there can be often a financial contribution ranging from £300 to £3,000 depending on their income streams. So I think in your case maybe it was a financial contribution that they had to make, and that would be them that would have to pay for that. You, the housing association, never pay for that or rarely pay for a top-up. Great Well Homes are is the only housing association that actually pay 50% towards all of their adaptations, because they do see it as an investment and improvement in their property. But any financial contribution under the means test or any top up over the £50,000 that's been said would have to be made from the applicants, yes.
Yeah.
And finally, my final question, I'm really pleased that children are now really being taken on board when, you know, you have disabled children, but the house isn't actually fit for purpose for them to be there. So there is now more money for children who have disabilities. Is that correct?
Yes, we've always provided children's DFGs. We've always provided DFGs to the under 18s. I think one of the suggestions when I went through the Executive Advisory Panel in Scrutiny was to consider means testing parents, but that was obviously a no-no. So we now don't means test any parents. So all children under the age of 18 will get a disabled facilities grant, because their parents' income could change in the future. We don't want to put that financial worry or burden on them. So no, it has always been the case that we provide children DFGs, and we will continue to do so under the legislation.
Yeah, and just to reiterate, grants have been available for children. They've always been available. It's not something we've just introduced.
I think some parents were concerned that their income, what they were actually earning, would be a hindrance in actually getting grants. It's not now.
It was considered, but
it's not now.
it was taken out at recommendations of EAP and Scrutiny.
Yeah, thank you. I think you'll be fine with Great Well Homes, but places for people you may struggle with. So just thank you, wonderful discussion, and thank you, Amy and Mark. Just some recommendations by this panel after this discussion. So this committee recommends that the local authority prioritises the development of new procurement framework, which you've discussed, to expand the contractor pool and improve availability, ensuring timely completion of adaptation works. And secondly, to report, you mentioned this in discussion with Councillor Anslow, to report of the progress. So officers to provide an update to the Health Scrutiny Committee later in the year regarding the figures of completed DFG projects. So I've just done the recommendations. We've concluded the questions, but I can open it up for one final question, if that's okay. Please.
One thing I did actually bring up at an exec meeting, if you remember the last one about this, where you put chairlifts into houses, when the person sadly either is deceased or they move houses, why don't you use the chairlifts instead of just bugging them in the bin and not use them again?
I seem to remember we answered that at the exec, and I can't remember the exact answer, but a lot of them, it's going to cost a lot more to rip it out and reinstall it in, and it won't. Most chairlifts are made to measure. So ripping a chairlift out of one property and then trying to retrofit it into another will cost more than buying a new one and putting it in. So a lot of the time, it's just pure economics that it's cheaper to do it that way, unfortunately. And we don't know the age, we don't know the maintenance condition, because on the old grants, we only gave 6 months of warranty. Now we're giving 5 years. So at least we know on moving forward, the chairlift will be properly maintained for 5 years, but older ones, we just don't know the condition of them. It's too expensive to retrofit.
Yeah. Thank you. Thank you. Thank you very much, Amy and Mark. Okay, on to the next item of the agenda, the Health Scrutiny Work Plan. Raj.
Yeah, so again, the briefing note relating to school exclusions and homeschooling will come later this week. And post-May, following the election, we have a few items to be scheduled on the forward plan. These include family hubs, ICB GP primary care access, the KGH patient pathway, the homelessness strategy, the impact of VAT on private schools, and finally, child sexual exploitation through social media. And yeah, that's all on the forward plan to be scheduled.
Wonderful, for the new committee, whichever's formed. Thank you, that closes the meeting. Cheers.